Some companies were getting fantastic responses and really good engagement. Surprisingly, some companies which you wouldn't expect. For example, I think one of the first companies that actually reached out to us or engaged with us after we'd sent them the survey, and their rating was an oil and gas company. So you can imagine that the ethics of an oil and gas company is probably not what you'd expect. And then you get sort of responses which are kind of like, yeah, we're thinking about this, but not right now. And then other responses are complete blanks. But I think just on the point that Krishna said, the impact of reputational risk, I think, is also driving what's driving most of our interactions with clients. And I think that's a really important thing. I mean, you needn't only look back a couple of months and you'd see another AI ethics problem and an issue gone completely out of control, and then the value of that company deteriorates and it has reputational risks, so people don't use them anymore, which I think is why an organization like For Humanity is so important, and it interacts with our model as well. I suppose when a company releases their accounts, they don't just get signed off by their board of directors or their audit committee. It goes through usually a strict and stringent audit process by, one of the big four usually, and then that creates that element of trust, which people, when reading the reports, they say, right, this is audited by an actual auditor. Obviously, you can ignore the incident of Enron, but then you have that audit and that trust there. And like you said, Ryan, this industry is only going to get bigger, and having that independent third-party audit is hugely beneficial. And I think as well, with regards to ethics grade, if a company has had an AI report and they even disclose it with us, then that's hugely beneficial for them and will likely lead to a higher score that we would give them.
Balance between accounts which are really mature in terms of putting machine learning models out in the market, and they taking proactive action at the the line of business stage to ensure that they have the right discipline to ensure oversight of the system, versus a category of accounts where the board and the C-level executives are like, wow, as we are taking more and more systems and making them machine learning centric, it's going to be very important for us to proactively tackle risks and also create opportunities
valuable to your process.
Absolutely. So it's interesting because I think, Will, you might not know, but I've been in discussions with Charles around how we can use ethics grade as either a oh shit moment or a oh wow moment, because the scorecards you're creating, the first time I, as an executive stakeholder, let's say from Twitter, sees it, I'm like, oh shoot, that I have this massive gap that I've not paid attention to. What can I do? And now the question becomes, what can I do? And this is where Credo AI comes in, because we provide you everything from, when you're thinking about an AI application all the way to when you're putting it in production and actively monitoring for compliance changes. That's what we help operationalize. But even if you don't have those oh shit moments and you have these, wow moments, that we are ahead.
Hi, hello. Welcome to day 2 of the For Humanities at Go International Conference. I hope you're able to tune into the discussions and insights shared by so many yesterday. My name is Chris Leong, and I'm delighted to moderate today's industry panel discussions on healthcare and AI. I'm joined by a panel of experts and industry practitioners who I will introduce shortly. Unfortunately, Roberto Zicari was unable to join us today and has sent his apologies. A couple of housekeeping points to start with. There'll be a Q&A session at the end of the panel discussions. So please raise your questions in the Q&A chat panel in the meantime, if you have any. And we will also be conducting a poll as we discuss each topic. The polls will be closed just before we discuss your questions. Without any further delay, let me introduce the panelists. Ajinta, let me. Okay, here we go. Ajinta is a physician innovator with 20+ years experience in medicine across the UK, Australia, and US healthcare systems, who's passionate about healthcare technology innovations across medical devices, drug discovery, and digital health, with a special interest in artificial intelligence and blockchain technologies. She's a leader who advocates and acts for human rights, meritocracy and diversity and inclusion. So, Ajinta, would you like to further expand on your background and tell the audience about areas which would be of interest in today's topics for discussion?
Yes, thank you for the kind introduction, Chris. So I'm an anesthesiologist by training and also specialized in public health. And much of my work was, I did a visiting scholarship at Stanford, and much of my work there was around perioperative care and improving that service. Obviously, with COVID, we transitioned to helping with COVID response, so have implemented a travel and employee health platform. So the 3 pillars of work that I use AI in is really for improving access to healthcare, so access and health literacy or health education. We'll look at how we can use AI to improve, or automation to improve operational efficiency, and that really ties more into also healthcare economics. And we did some early work in disease analytics, so trying to recognize patterns in various new diseases. So we're looking at COVID in particular, and currently we're collecting data, matched data of vaccinations and test data to try and track some of that information as well.
Thank you, Ajinta. Next on the panel is Giselle. Giselle is the founder of Engineering Hearts and Director of Design Research at Design Run Group. She designs health diagnostic services, applying human-centered design research and incorporating prevention and wellness options within the federally qualified healthcare centers. That's FQHC community offering. Her experiences within diverse organizations in education, biotech, information technology, energy, semiconductor, real estate, and healthcare brings a multidisciplinary point of view to ethics, technology, and engineering. She's also a contributing member to many IEEE engineering standards, including 7000, P7004, P7008, P2418.6, ECPAIS certification, and P2089. She's the chair of the forthcoming IEEE AI Procurement Working Group P3119. Giselle, would you like to expand on that and provide some more background on where your work might be related to today's discussions?
Sure. So I have a PhD and my research skills have been applied to these various verticals. But what I'm in now is the granular operational and commercialization of AI in healthcare through prevention and wellness. Essentially software as a service, services that are being used to now provide an option to seniors in a federally qualified healthcare center in order to look at how diagnostics can be used to get ahead of where they are in terms of their various medical conditions. And so a variety of diagnostics will be used that use machine learning and AI in order to look at multiple biological systems and begin to treat them across a year of potentially changing behavior and changing their lifestyles in order to improve upon them from when they move into Medicare and then across time. And so it's an interesting intersection between what's happening, that sick care is now moving into value-based care, but this is an option, a mechanism by which we get ahead of any condition by using prevention and wellness diagnostics that, of course, draw from AI and machine learning. So it's a complete redesign of senior care. And it's an interesting opportunity that it's a real use case example, for example.
Thank you, Giselle. Fantastic. And finally, we've got Wen. Wen, for some reason, your bio has disappeared from the platform, so I'm going to pull it up on the side. So apologies for the slight delay. So Wen Zhao. Wen is the Group Chief Data Officer for Prudential PLC. Wen spent over 20 years in telecom, pharmaceutical, and insurance industries in the US, UK, and China. He's an expert in end-to-end customer experiences, digital innovations, data governance, and IT development and operations. Wen joined Prudential in 2006. His most recent accomplishments include leading the AI marketing campaigns to deliver 12 million application installs in 10 Asian countries in 1 year. He defined the data strategy and data policy for Prudential Group, leading the implementation of master data management platforms across 7 markets in Asia, driving innovations by integrating the latest digital technologies into Prudential's digital ecosystem. Before joining Prudential, Wen ran AstraZeneca's IT operation and infrastructure in APAC and LATAM. Prior to this, Wen spent 10 years at British Telecom and held a number of executive positions, including COO of BT China, CTO and CIOs, etc. Wen held 2 master's degrees from MIT and in supply chain management and MBA in corporate finance. Welcome, Wen. Would you better please give a bit more background on where your experience would be applicable to today's discussions, please?
Sure. So I'm the Chief Data Officer of Prudential Group. For people who may know, Prudential is one of the oldest and most successful life insurers in the world. But we, from 5 years ago, we are reinventing ourselves to become digital ecosystems around health and wealth. And we launched our consumer app called Pulse by Prudential 2 years ago. The app is packed with AI features like symptom checker, health assessment, and we use the data to help our customers provide personalized services and products that are tailored to their individual needs. And so far, I think Chris mentioned 1 year we acquired 12 million users, and so far, after 2 years, we have acquired over 30 million users in 10 countries in Asia. And it opened up so many opportunities for both Prudential and our customers, but it's also posed a big challenge to our data infrastructure because the data we collect from the digital ecosystem is very different from our traditional business in terms of scale, scope, speed, and variety. So as CDO, my role is to build the governance structure, the people, process, and technology to ensure that we manage data effectively throughout its life cycle and create values for our customers in an ethical and controlled way. Thanks, Chris.
Thank you, Wen, and welcome all 3 of you. So let's kick off. So the first topic of discussion today is around what special considerations for healthcare, AI, and governance within organizations that deploy AI. What should regulators also consider? Fairly broad topic. Yesterday, we heard from the EU Commissioner, Paul Nemitz, about how AI systems classified as high risk needs to be regulated under the proposed EU AI Act. Clause 75 references conformity assessment for medical devices, as well as the use of biometric data. Currently, where AI is used in healthcare, from instances where it analyzes data to present insights and information for the physician or the consultant to diagnose the patient's condition, so human in the loop and human on the loop, right through to triaging a patient's condition based on biometric data inputs to present a diagnosis based on how the model is trained, where do you see challenges in accuracies and the consequences that warrant regulation? Similarly, we have the current AI-driven products and solutions, similarly, have the current AI-driven products and solutions undergone regulatory scrutiny before they were deployed in the marketplace on people? So it's touching various aspects of the use of healthcare, AI in healthcare. I'm going to start with you, Ajinta. So given your experience with healthcare technology innovations across medical devices, what are your insights on this or your thoughts?
Well, I think with medical devices, there's a few challenges in the sense that they're obviously very useful for providing new insights and increasing some level of efficiency. But what a lot of doctors are seeing is that, say, with electronic health records and new technology that's being implemented, that there's increasing administrative load. So if you actually look at the labour statistics, the number of doctors hasn't increased, but the number of managers and administrative workforce in healthcare has increased, which has ballooned healthcare costs. So I think the focus has been on investment in sexy things like diagnostics, whilst actually we need more investment in operational efficiency and reducing burnout and reducing distractions to care. So when I say distractions to care, you can have a fancy new technology which is collecting some data and you can produce some insights. Whether those insights are applicable in entirety to that patient we're still at very early stages with AI. AI's been around since 1956 was the first implementation of clinical AI services. And the FDA in the US has been working with AI. They've had a special AI unit since the 1980s. And they've been, certainly the director has published various things on real world using real world data. So we're getting closer and closer with AI to things that can be implemented in in the diagnostics world, but I still think we're a fair way ahead. So I think it is still very much high risk and, where ignorance is sometimes bliss. So you might think that say with COVID, you saw a lot of symptom checkers out there. In my mind, a lot of those symptom checkers miss a lot of data. So they're useful as a kind of like a commercial device. I wouldn't say commercial necessarily, but as toy is probably the wrong word, but I would say you have to be very cautious in using them because they have a lot of missing data. So even the electronic health records miss about 30% of clinical data. So how are you going to create an AI system that is going to be reflective of a human in the loop or on the loop, i.e. to replace them? I don't think we're going to get to that stage. And one of my concerns is that if there is a human in the loop and human on the loop, that they should be very aware of the data that the AI might be missing and any bias that there might be in that data set. Because one of the real risks of AI is that you can have an error that is amplified multiple fold because of its scalability. So if a human makes an error, the error rate is X%, and the error is confined to the limit of that human's interaction with the patient. Now you have an AI system that deals with millions of patients, so you have one error which is now amplified. So I agree with the EU Commissioner that this should be considered high risk. We should move cautiously, and we should certainly have a feedback system built, and we should recognise all the challenges that are there as we move along. It's not to say that we shouldn't have investment in AI, but I think we should have, we should definitely have investment in AI, but certainly we should be also focusing our efforts in terms of AI in healthcare for administrative operational efficiency, improving access, and reducing the burden on the physicians who are giving you that data to create improved AI systems. But AI is very beneficial for obviously early detection, prevention, personalized care, and I think for the future in terms of longevity, so improving how long we live, AI is going to become very useful for all of this.
Great, thanks, Ajinta. So Wen, do you see many similarities in what you've tried to do or done through Pulse as well?
Yes, I just want to pick Ajinta one of the points Ajinta talk about the early detection. It reminded me, I met a company based in Oxford. What they specialize is to using pattern recognition to analyzing AI to analyzing X-ray images to detect early sign of lung cancer. And traditional doctor, well-trained doctor, they look at the shape, the size, and the color of the shape to identify early sign of cancer. But with AI, it's something AI can do, machine can do much better than human. He can detect early sign of lung cancer 1 or 2 stages before the human doctor can. And one of the questions people ask is, okay, are you going to replace the lab technicians, right? Or doctors? He said, no, but we make them more efficient. So of course, we still have the human in the loop, human above the loop, but this is you can use as a second opinion or early sign. They still have to go through human. So I think the AI is great to support. It has great potential for healthcare, but it's not going to replace human, but it could make human much more effective. Now, in our example for Pulse by Potential, we have a number of features, like I mentioned earlier, symptom checker, not just for COVID, but for all the, not all the diseases, but all the common diseases. where a user could chat with AI doctor for triage and diagnosis. It's very similar to the NHS one-on-one service. So we partner with Babylon Health from UK, whose platform was actually granted GP status by NHS. It was really welcomed by regulators because we make quality healthcare affordable and accessible for hundreds of millions of people in countries like Indonesia, and Malaysia, and Vietnam. We can argue, are they good? Are they good enough? Were they perfect? Probably not. But if you think about the situation in Indonesia, in Malaysia, where people have to travel, days to see a doctor and queuing in lines just for 5 minutes diagnosis. So this make quality healthcare affordable and accessible to millions of people. And when we launched the app in Malaysia, actually the health minister was our keynote speaker. I think Ajinta and Chris, you are right. There's a special consideration for healthcare is that the cost of making the wrong decision. So when Netflix recommend me a film that is wrong, not what I wanted, what's the cost? Zero. But if the AI make the wrong decision or diagnosis, people die. And AI is also very different from other technologies because it has a power to make decisions, and it can evolve on its own with building and learning capabilities. This, as Ajinta touched on, this may result in impacts which are more widespread and at great speed. As she said, if you make one mistake, it could impact millions of people. So therefore, the governance, I think that's what you question, should be more rigorous and in addition to the normal IT governance. So in Prudential, we published our AI governance policy at the end of last year. So it lays out the process and the governance framework, how we should roll out AI to our customers. For example, who is accountable? We hold the model designers accountable for not just the model, but also its input, outcomes, and risk. We also have a quite established process for testing and evaluation. We call it alpha, alpha plus, beta, gamma, omega, and omega plus. And at each stage, the model designers will have to present to the governance council the performance in the model and the council's approval to the next stage. Now, the governance framework is also what the regulators look for to get confidence that the company has a robust process to ensure that they use healthcare AI legally, responsibly, and ethically. And that helped us to roll out Pulse in 10 of the countries in Southeast Asia.
That's great. Thank you, Wen. And Giselle, welcome back.
Thank you. Can you repeat the question? My computer decided to die. I'm so
okay.
sorry.
Yeah, we're just talking about the special considerations for healthcare AI and governance. I'd like you to share your work with IEEE, especially around the P3119 standard on artificial intelligence procurement. How do you see that sort of helping the healthcare industry procure AI that's been developed responsibly?
Right. So as chair, we've got about 40 people, 10 different countries, and these are procurement professionals, lawyers, social scientists, data scientists, a lot of socio-technical domains being represented. But we're starting at baseline here. The standard is meant to do basically two things. Our scope is to create a uniform set of definitions for AI procurement for government entities. That in and of itself, when you begin to derive and analyze and critically evaluate a taxonomy and an ontology of a domain is difficult enough. So the standard will first create a uniform set of definitions for AI procurement that government entities can use. And also we are aiming to create a process model with process requirements that government entities can sequence through in terms of events that are required. A slightly derivative, perhaps best in class for what occurs in procurement usually in government entities, regardless of jurisdiction, regardless of level of jurisdiction. My aim is to really find process requirements that transcend domain, transcend context, in which a global set of entities can look at it as a useful tool to try and derive some parts of the impact that would look at, like you said, when the impact of outcomes and inputs and outputs and outcomes, but that would be a slice of the procurement sequence of events in the process model. So we'll take this brain trust that is part of the working group now. We haven't yet kicked off. It'll probably be the beginning of October, but we're looking forward to discussing as a global group at least the beginning of an ontology that at IEEE folks can use in order to understand in multiple domains, multiple jurisdictions, what is it that we're all talking about. Beginning with a common language is so important. Labels are important. Each word is important. And so I look forward to that kind of work.
Great, thank you, Giselle. So for those of you attending, there's a poll question that's been posted already. So please take a look and put in your option. Let's go on to the next question now. Next topic, basically. Does the sensitive nature of healthcare data present extraordinary challenges for privacy and cybersecurity? It's a fairly loaded question. So I'll give you some context. So in the UK, we're seeing this being played out where about 3 weeks ago, The Guardian reported that more than 1 million people opted out of the NHS data sharing in 1 month in a huge backlash against the government plans to make patient data available to private companies. Under the scheme, GP health data for everyone in England with identities partially removed would be made available to researchers and companies for healthcare research and planning. And this scheme is more extensive than the current GP data sharing arrangement. However, people are electing to opt out. So what clearly personal healthcare data is sensitive, right? So we're looking at privacy and cybersecurity here. 2 pillars of the 5 pillars under the For Humanity lenses. So I'll start with you, Giselle. What are your thoughts on this, both from a privacy and cybersecurity perspective?
Well, from the patient's point of view on those 2 issues, various qualitative and quantitative research shows that for medical research particularly, patients are not very comfortable at all with folks using their data without permission and without consent. It happens all the time. But generally speaking, you have numbers between 60 to 75% saying, you know, I'd really like to be told, I'd really like to be asked. At the same time, from another privacy perspective, we have an older generation now, 45 million strong in the US of seniors, soon to be in 10 years, approximately double that, 80 to 90 million seniors who, when taken from a small sample of their understandings, their approach to privacy, would probably say, hey, I'll gladly give up some privacy and gladly share amongst my providers the data as long as you can coordinate my care. So the coordination of care is probably a higher priority than privacy in many, many instances. But still, you know, from the patient's point of view on that, it's super important to access and to give permission and to provide consent. That would probably be my comment.
Great, thanks. So I mean, obviously, when your experiences in Asia Pacific or Asia and then Argentum or US currently, so I see potentially geographical cultural differences at play in the way their population. Obviously, Giselle, you touched upon this as well, right? In the US senior population. So I'll go to you, Argentum, first on your views and experiences in obviously US, UK, and Australia where you've worked in. So what are your thoughts?
Yeah, I think there was actually a question which aligned very well with this topic as well. So the question, I'll just also read out the question and then I'll answer both. So the question was, what are your views on the ethical and infosec elements of the use of AI in healthcare, specifically hacking, data bias, being race, disease, ethnographic components, and algorithmic fairness? So I think we'll take just the cybersecurity hacking element to start with. Obviously, healthcare data is very, very sensitive, personally sensitive information. And I think there is cybersecurity risk, and certainly around, say, with COVID, when a lot of data was being collected and there's a lot of relaxation on the regulation around, vendors collecting this information, there is a delayed, I would say there's possibly a delayed risk. That said, I do think that we've made great leaps and bounds in terms of cybersecurity and improving technology to protect healthcare data. So there's been a lot of work done in regards to, privacy preserving technology, various encryption methods, decentralizing data, de-identifying or separating out identifiable data from de-identified data, etc. So I think there is great technological improvements that the public may not be fully aware of yet. So I think there's a lot of mitigation that is being done in terms of the risk from hacking. That said, we will always have to be, alert and responsive and put preventive measures in place for that as well. So I think from a cultural perspective, Chris, I do think that certain geographies are more sensitive to privacy. So, Northern European, Northern American countries tend to be more sensitive. But that's also partly, not just from a technology perspective, but also just culturally. They're just more private individuals compared to Asian communities. So certainly I've got a Asian Indian background, but, I very much kind of have a multicultural circle of friends. And I know from the Asian circle, we tend to share a lot and tend to share a lot of information. So the minute someone falls ill in the community, the whole community hears about it and everyone floods the hospital, as an example. But that is not the same in kind of Western societies. So I do think the East-West is slightly different in terms of privacy and privacy concerns. That said, we also all have to be careful because when it comes to AI, we don't know how that data is going to be used. So if it's, in a community, that your data is going to be used, not necessarily maliciously, but for someone to say, visit you and give you support, like mental health support and others, physical care as well, or bringing around dinners, etc. when you're sick. But if your healthcare data is exposed on a platform with people who don't know you and who may be transacting with that data, such as your private Medicare numbers or your social security numbers on the dark net or whatever other system, that's obviously quite a concern. So I think even the East is becoming a lot more alert to this. But I can see why in the UK there was an instant backlash. I do think that one way to respond to that, and certainly from a governance perspective, is education. You really need to improve people's health technology literacy. And I found certainly with my medical practice that when a patient was made aware, even if there was a complication or something that didn't go to plan, if you have a conversation with them and keep the lines of communication open, explain things to them, then you're not going to find a backlash. You're not going to have to even worry about litigation risk. It's only when you try and keep people in the dark and you try and pull the wool over their eyes or you try and cover up, that's when you're going to find problems in terms of cultural problems anywhere in the world. I think that's human nature.
Wait,
sorry.
No, go on. Yeah.
I'm taking a lot of time on that topic. So just quickly on the bias part. I do think that obviously the data is only as biased as the input of the data that we put in. So actually traditional healthcare research, I would say, probably was more biased than healthcare research now, because they tended to have smaller data sets and it tended to be wealthier nations doing more research, or certain types of nations, so with certain types of access to culture, that would be doing the research. So the famous cardiac Framingham study was done in white male population predominantly. So it was thought that white males were more predisposed to heart disease. Well, it's actually a Canadian study came out to show that the Ottawa study, that females are actually, just as at risk of heart disease. It's just that the study population reflect it. I think the beauty of AI is that we now have much larger data sets from a much more diverse population. And maybe what vendors can do is to be transparent about the various demographic features of their data sets. So that's commonly, written up in studies, in research papers in medicine. You have a section which you outline the demographic details of your study population. So AI systems can do the same. They can be transparent about who's part of their customer base and what are the demographic features. So then people can say, oh, that platform has, you know, this diversity matrix, etc., or diversity index that's more reflective of them. Or if they have a rare disease, you know, there's somebody else on that platform, on another platform with a rare disease that they might want to hop onto.
Excellent, thank you. Wen?
Yes, I think the Guardian, I'm not surprised about the Guardian report, especially in UK. I think as Ajinta alluded, it may be related to the recent COVID the situation. And we all know that privacy and consent, they're absolutely the bread and butter, right, for any data governance. In countries like EU and China, actually all the jurisdictions, we have a very, very well regulated laws on privacy and confidentiality. In EU, we have a GDPR, and in China, we have something called PIPL, which is Personal Information Protection Law. But it's interesting thing happened in the last 2 years is that patients' privacy has been, in my mind, greatly compromised during the pandemic. So, for example, you know, all the countries have implemented, all the government have implemented some kind of track and trace capabilities during the pandemic. And to a large degree, they were accepted by the public. In the extreme case in China, and the government would disclose the patient's address, where he lived, where he had been to in the last few days, you know, hour by hour, and at what time. The intention is to alert the public that anyone who had contact with the patient or happened to be in the same place at the same time to be tested and seek medical help. It's come up with good intention. And in some cases, the government would seal, not in some cases, in all the cases, even today, if there's a case being identified, the government will seal the building where the patient lived, and everyone has to be quarantined for 14 days, if not longer. And you can imagine the frustration of the people living there, and they voice their angers on social media towards the patient, who we all know is not their fault. And it's not just China, right? All governments have implemented some kind of track and trace capabilities. So the interesting question is, so whether personal privacy and the patient confidentiality should be sacrificed for the greater good of the public. Right? I think during the pandemic, the answer is probably yes. But where should we draw the line? And who should decide it? I think that is probably explained why the UK population, you know, I don't say it's a lot of people, but quite significant amount of people, they withdraw their consent, they opt out, because I think this incident, even though it was designed for the good, with the good intention, but actually create doubt in the mind of the public. You know, where else would you sacrifice my privacy for the greater good? Now, and I would love to hear the views from the panel and maybe audiences, what their view on this.
If I may, I read this the other day. I love what you're saying, because it really brings it back to sort of a humanity question and not a geography or a jurisdiction or policy question. Really, it's about being humans, Homo sapiens, and I've written about this in a book. It's a chapter of information security on the notion of pandemics. But can we move away from us versus them, us versus nature, us versus them versus us versus nature? And a question that was asked in someone else's text was, when does anyone else's freedom or my freedom interrupt with someone else's need versus my need? So it's when freedom and need can collide, are in conflict. And so what does everyone think about that notion? It's an interesting perspective, because one person in one geography will answer that in one way, who has a variety of experiences and cultural backgrounds and religious background and so on and so forth, everyone's cultural context will answer that question a little bit differently. But what does the rest of the panel think about that? I'm just trying to extend what you said, which I think led directly into that.
Ajinta?
Sorry, I missed part of that, Giselle, I must admit.
It's okay.
Well, do you want to come back to that at the Q&A side? Because we need to just park that.
Yeah.
Emmanuel, can you please make a note of that question, and then we can come back to that, please. Thank you. All right, let's move on then. Let's talk about medical ethics and the way AI is used. Okay, so I think this topic, some of the things you've said have touched on this already. Okay, and let me just frame the context. As AI-powered software provide capabilities for individuals to obtain insights into their digital twin, or I read an article and it refers to it as quantified self, okay? Promoting self-service models for continuous personal healthcare versus traditional healthcare that were provided by health professionals. How do ethical responsibilities of medical professionals get integrated into these scenarios? And what additional responsibilities do the developers and firms producing such apps need to take on? So how many of the AI models were tested in a setting that was different from one which they were trained? And were they under the supervision of the relevant and respective medical professionals? So basically everything is now, encapsulated in an app. Obviously medical ethics, right? Is that also encapsulated? That's the question. So I'll start with you, Ajinta. Your thoughts, please.
Yeah, I think the future is having a digital twin, quantified self, and personalized healthcare. That's certainly where we're headed. The challenge at present, I feel, is that where these vendor or these developers are developing the digital twins, they are possibly utilizing healthcare professionals as advisors or maybe even on staff to help them develop these. But they really have to, I know of a number of companies who are probably using the wrong type of specialist in terms of an MD. So being an MD does not make you a generalist. It makes you a generalist at a very certain level, but not at a specialized level. So in medicine, there's, Wen would know this already, or can speak to this, but there's general practice and then there's various specialties. So if you're developing, say, a application, I've seen this before, there was a application being developed for anxiety, and it was monitoring you continuously and even giving you prescriptions for anxiety medications. The MD on the board of that was a dermatologist. So I went out, we were out for dinner with that MD saying, you should be careful, there's all these other risks with that prescription service that you're offering. And obviously this is in the mental health realm, not in the dermatology realm. So I think there's one thing about when app developers or vendors develop things, they have to use the right professionals and at all the different stages. Difficulty is going to be when the patient presents also to their family physician or their specialist and says, hey, my app is telling me this, and insistent, or like a TV ad for a certain drug has given them some insight they could have, and the physician may not have all the information at hand that's been put into the app, so they can't necessarily use the app really for their clinical care or as an insight. They can certainly kind of point to it. They can use it in the sense of as another piece of data, but they can't necessarily use it, and they certainly can't, I'm not sure that they can defend themselves if there was a litigation case. If something was to go wrong, they can't say, hey, I use the information from the app to guide my clinical decision making. So I think that's, all of that has to be worked out before we can say we're ready to fully adopt this. And this goes back to regulation, governance, and implementation, cautious implementation in the clinical setting.
Okay, I've got a question around that. I think you've touched on FDA. So have you seen FDA getting involved in approving these apps where they get actually giving prescriptions? I
have to say I haven't checked recently. I have to check. I do know that there's various algorithms, AI algorithms that's been approved by the FDA for diagnostics. So somebody asked a question before about the black box algorithms. So where there's algorithms that are showing so what you do is you compare your algorithm against a control or a human data set. And if the algorithm outperforms that of a human, like when said with radiology in, say, detecting small tumors, on images, if the algorithm's outperforming a human, then it can be approved. I'm not sure about approvals for prescription apps. I haven't come across it yet. I've come across the AI algorithms for diagnostics.
Okay.
Some of them being approved, yeah.
Great, thanks, Ajinta. Giselle, what are your thoughts?
This is it's a Gordian knot. Certainly, you need as much help from what FDA can extend to, but even before AI, right? Medical devices have a lower bar of approval than medicine itself. So without even AI complicating the approval of medical anything in this field, we have a lower bar for medical devices. Now you add in the artificial intelligence where software as a service is being provided for diagnostics. That's one application. And you have this degrees of separation as they go away from the patient and knowing what the outcomes are for the patient, let alone large populations at scale. So will it take a long time for both regulators and standards and vendors themselves to care at the individual, at the group, at the organization, and at the jurisdictional level? Absolutely. Are we way far away from that? Oh my gosh, so much so. So much so. I mean, even just the AI application for the diagnostics that are looking at biological assessments of your various physical systems, none of that data was put through any kind of oversight in any way, shape, or form. I'm sure they have their own private sector IP efficiency audits of how well those are, how accurate things are, how great the model is acting. But whether or not, for example, even in the populations that those biological assessments were used in, typically athletes or really, what do you call those? Quantified self individuals and folks that are at the cutting edge of wanting to track everything, we're going to take from that and now apply it to seniors. Do so in a very cautious way, as Anjanta stated, but none of that has been looked at and critically evaluated in any way, shape, or form in this next project. And but with the most cautious organizations, even with high mission-oriented folks that are purposeful about what they do, you still face all of the technical, federal healthcare information technology regulation. So there is this large way of how will we organize the data, but it's not necessarily about patient outcomes. It's not looking critically at what's going to happen or what that diagnostic is saying about patients. So we have a huge gap between what could be and what is.
Okay. Wen, just to round up?
Yeah, I'm not a medical or a professional, so I think I agree with both ladies said, but I want to provide from a different perspective, from the policy and governance perspective. So in this topic is about ethics, right? So ethics in AI. So in 2018, the Monetary Authority of Singapore published their AI ethics principle, known as the FEAT, F-E-A-T, which stands for Fairness, Ethics, Accountability, and Transparency. It is not a regulation, but it provides companies like us, firms, with a set of foundational principles to consider when using AI in decision making, and also to promote public confidence and trust in the use of AI. I'm just quoting the document. Mm-hmm. So in Prudential, we also have 8 AI ethic principles. And the first one is value. And it's loosely based on the Hippocratic Oath. First, do no harm. So before we even considering talking about the design or assess whether the AI system is good enough, the data set is comprehensive enough, before even we do that, the designer had to answer the question, how the system they're designing will benefit users. Now, another principle is what we call the transparency and explainability. So we make it clear to customers when and how their data and AI is being used, and we will make it easy to understand how AI has been applied. So even though AI itself, may have a life on its own, like it's a black box, but we need to make the designer need to make it clear and simple to explain, able to simply explain what is intended to do and how they're going to use the data. I'll give you an example. In healthcare, in Prudential, in insurance, in our app, we collect a lot of customer data from our Pulse app, like health data, lifestyle data, fitness data, etc. But we do not use those data to create discriminatory pricing. We use the data to provide personalized products and services that tailor to the individual needs of each user. And the point is, we could, using the data and to penalize or award people with different lifestyle. But just because we could doesn't mean we should, because we have AI as a form. We have to comply with AI, our AI ethics principle. And I think all the companies who are rolling out those technologies, AI technology, need to follow the similar principle, if not the Prudential way, but at least for the Singapore way, right? Fairness, ethics, accountability, and transparency. Now, in another things principle is called fairness. So we do not discriminate against people on the basis of factors that are outside of their control. For example, their race, gender, there's not their control. And we also systematically assess the data we used to train our data models. So I think at the end of the day, it's a firm's responsibility to ensure that the way we implement any AI technology is legal, responsible, and ethical. And also they must have a robust governance process to ensure ethics is not just what they do, but not just what they say, but also what they do. Yep. And if any company not following that, and then that'll be caught in the question. That's where the trust comes in. Is it a company we should be doing business with? Thanks, Chris.
Great, thank you. I think you've answered some of the other questions further down the topic, so we can spend less time on those ones later. So let's move on. Data sharing, disclosure, research, and consent. We've talked a bit about this already. Okay, so and we're running a bit behind. So let's maybe just add to what you've said before, rather than repeat. So the context here is consent is key, right? As you've mentioned many times in many of your responses. Given that healthcare data is personal in nature, GDPR, I think when you mentioned that, provides a regulatory framework to protect data subjects in the EU and UK, obviously the UK version of GDPR. How much should scope, context, nature, and purpose of the use of data that people have given consent to, right, need to be disclosed up front? And if so, should consent be explicit, and should it be limited to what is disclosed? Because I'm thinking here, right, data can be further shared, could be sold, could be traded, could be, third parties in the supply chain here. Do any of you foresee challenges in the integrity of how AI is used in your third-party services and solution provider, especially when it comes to upholding your own code of ethics and code of data ethics? So Wen, I'll start with you because you sort of touched on this.
Yeah, so I think go back to the FEAT framework. I think that they made it clear. This Singapore government says, recommend the framework is the company who roll out the service are accountable and responsible for the outcome. If you could use third party or third party, it doesn't matter. You are accountable. You're held accountable. If you roll out this service, you are held accountable for the outcome. Right? That's also your question about third party. Yep. But I slightly disagree with this question. Is I don't think those issues, data disclosure, research consent, and data sharing are necessarily competing. Now, I would go for 100% honest, open, and transparent. about what data you're collecting, how are you going to use the data for, and what's it intended to. Now, I think that's, for us, it's not just to comply with the law, but also align with our AI ethics principles. And second, I found, in my experience, we found being open and transparent actually help us collect more data. I'll give you an example. In our Pulse app, there's a feature called Bmi Checker. So basically, when customer take a selfie, and the app will estimate your age and BMI. Now, as you may know, that in insurance, over 90% underwriting accuracy can be gained from just 5 parameters: age, gender, BMI, smoking status, and location, right? So this feature helps us to provide a frictionless health sales experience. Now, our competitor launched a similar service, and it's reasonably accurate for Caucasian population. I think as Panas mentioned earlier. But with people with East Asian origin, it underestimates as much as 40%. So we need to train the service with actual people in Thailand. That's where we launched the service. And we launched a campaign called The Face of Thailand. We're transparent about the purpose of the campaign, and we got thousands of people signed up. They participate and provide their personal information to train our data. So I think that's why I think those issues are not competing factors. As long as you're open and transparent about what you do and why you do it, if it's the right thing, you will get people support. And equally, if you don't get a lot of support, you may need to ask yourself, is this the right thing for you to do? Is that going to benefit the customer? Thanks, Chris.
Great, thank you, Wen. Yeah, Giselle, you next.
Can I challenge Wen?
Yeah.
When you were marketing or doing the outreach to get the data on these 5 vectors, was there any sort of disclaimer or qualification saying, we know from these 5 things that your insurance can go up or down based on what the results are? Was there any kind of just a disclaimer saying any information that you give us will not be used to take away insurance from you? Was there any part of that kind of messaging in your outreach?
Currently, it's a service we offer as a free. You take a picture of your selfie, and you get a BMI and estimate. But we haven't used that for sales.
Okay, gotcha.
Yeah.
Okay.
So right now it's a free service called Bmi Checker.
Okay.
But if we do use that for underwriting purposes, absolutely, we disclose.
You will. It's scary. It's scary.
Giselle,
Very scary.
Giselle, while you're there, do you have anything else to add to the question?
Well, I look at it from, my father has 8 specialists. We walk into a medical office, and I'm signing consents for him. He can't see very well. He can't hear very well. I'm signing consents digitally on this little itty bitty pad that looks like one of those, cashier pads at the office. And I'm saying consent. I want to consent. Probably in a minute or 2, I'm consenting, I don't know, to 15 different things for my dad to get coordinated care. Now, I don't know any of the terms and conditions in any of what I signed. All I know is that in the minute that they are registering my father as a patient, I want whoever looks at his data to talk to each other and to coordinate care. Does it happen? I don't know. Does the patient in any way, shape, or form understand what he's consenting to? No, absolutely not.
But you trust, obviously, you trust the specialist that you've got.
I have no choice. This is not retail.
Yeah,
he's going to get medical clinical care.
Yeah.
This is not I want a TV or I don't want a TV and I want a better TV.
Yeah.
This is I'm seeing a doctor and he has to get care.
Absolutely.
So it's asymmetrical power for sure.
Yeah, we'll come back to the trust bit later. But Ajinta, do you want to round out on the question, your thoughts?
Yeah, I think Wen and Giselle raised the challenges. So consent is a very jagged topic in technology, because if you think about, say you buy an Apple MacBook, to use a MacBook, you have to say, I agree to all the steps. If not, you don't get to use your MacBook. Similar with healthcare and healthcare apps. If you want to use that service, unless it's optional, non-mandatory service, then you can obviously not consent. But if you need the care, you have to consent. And in litigation, this has been tested in kind of traditional healthcare, not really with the use of AI. So I think that's to come. So the courts will be looking at this and addressing this in the medical litigation scenarios as well, where you have to have informed consent. So there's, there's Montgomery, I think, was one of the more recent cases which looked at informed consent. And so I think that's where it's going to become challenging. I think what's going to happen with all of these applications is that the governance and the there's going to be governance pieces and regulation pieces, and in kind of a delayed format, we will start to see the courts get involved to start to create some kind of ex-ante policy around this type of the issues of consent. Certainly GDPR talks about data minimization and use of, disclosing use of the data only for the purpose that it's collected, i.e. you can't sell it necessarily to a third party, use it for another reason. You can only use it for the purpose that you've received consent for. But the question really will be, what is informed consent? Is this consent, and also is this consent, have you kind of forced someone into consent as opposed to truly optional consent? Yeah.
Great.
I just want to add one more point. I think I mentioned earlier. Just because you have the customer consent, you have their data, it does not give the company's right to misuse it. And that goes to the ethics. It's legal, you're legal, but also you need to be responsible, and ethics. I mean, for insurance company, trust is everything we do, right? It's more value more than we do. So just because you got a consent, you got the data, doesn't mean you should use it in the way that you see fit.
Great. Thank you. Which leads us to the next topic, which the headline is, how do we trust AI? Maybe I'll add another bit to it. How do we trust the company that use AI? I think that it's interrelated, right? Because AI is just a technology. It's dumb, right? Unless you, obviously it reacts to how you teach it and what data you feed it. So I think the people that, or the companies that design AI systems and deploy them has got a lot to answer for. So how do we trust AI, and how do we trust the companies that deploy AI? So quick 1 minute, 1.5 minute answers. We'll start with Giselle. How do we trust?
It's about people. To me, an organization is represented by people, and the interactions that organization has with people. If all of those things are positive, if all of those things are honest, if all of those things are principled, it doesn't matter what tools, whether they be machine or non-machine, a person is really entrusting another person, and by proxy the organization. So in the 180,000 patients that are represented that attend this federally qualified healthcare center, they are really engaging with the reputation of that organization and with the people that represent that organization. It has nothing to do with what bits and bobbles they're pulling out of their tool sets.
Great. Okay. Thank you. Wen?
Yeah. I want to go back to the conversation we touched at a point. So I want to answer the question differently. It's not how do we trust AI, is how companies, business like Prudential, should build trust about their use of AI among their customers. And that's why we established our AI governance policy, which provide guidance to ensure that we, the company, take responsibility to design, implement AI legally, responsibly, and ethically. And I wouldn't bore you with all the 8 principles. I touched some of them, but I think if I do business with somebody, a company who is rolling out AI services, the question I would ask is, show me your AI governance process. Show me how what is your value, ethical value you behold, and how you govern, make sure that your company, the technology you roll out, is in the user's interest and is transparent, fair, reliable, compliant, and also respect the policy. Now, I think the trust is actually a very important factor. I think I was hesitating whether I should say that or not, but if you look at why the Guardian article, go back to the very beginning, who is running the UK's track and trace program, and what she used to do, and why she left the previous company. And that casting doubt in people's mind. Are you going to safeguard my data, my critical healthcare data, and so that make sure that it works for me? I think in that aspect, there's a loss of trust in there. That's caused so many people opt out.
Yeah, the face of the firm or the face of the initiative. So who's leading that? Absolutely. So Ajinta?
I wholeheartedly agree with both Giselle and Wen, especially with transparency and fairness. I think there's also a big element of democratization, which obviously the World Wide Web and enabling everyone to join the AI race, is going to be very beneficial to improving trust. So that whole inclusivity, and I don't think it's necessarily about including good or bad or inclusivity of only things which are good, because then you're going to start to introduce bias. So you really need to have a balanced system. So you need to have those voices or those, that data set which is going to possibly challenge your other data sets, etc. So you have to think about how to get a balanced AI system. There was a question here in which said, and this goes to the question that you've asked, Chris. Somebody's asked, in most cases, AI is operating using black box algorithms. What happens if there is something fundamentally incorrect with the Basel algorithm? How can we build transparency or get under the hood of AI, of the algo? I think this goes to trust. So this is a concern about how do we trust this particular AI system or the algorithm. And I think it has to do with transparency. So with, say, the black box algorithms and the neural networks, you know your inputs, you know your outputs. You may be able to create kind of technological windows of indexes or various kind of data points that you can collect to see how it's progressing. And then you also can compare it to control. So you compare it to a kind of an input system and an output that you do know, that you do understand, that you believe is trustworthy, and you compare the Basel algorithm with that one and say, is it can it be trusted? So it's about, with AI, a lot of people think correlation means that it must be true. And that's not necessarily, correlation is not causation. So you can find the correlate that somebody with blue eyes will prefer pink shoes. That's a correlate. It's not always true that everyone with blue eyes will buy a pink shoe. It's just it's a correlate that you found in the system. So same with diseases, you might find, various correlation, and, in medicine you do randomized control trials, and also having large data sets is helpful in this. But I think it's about having various kind of in technology advances as well in research methods.
Excellent, thank you. So thanks for that, which leads us into the last topic. And before we go there, I just want to remind everybody that's attending, there are polls that Emmanuel has kindly posted. So please look at the questions and provide your feedback. I'd like to see where people are, what their thoughts are. So the last topic was about trust, and like I think most people would agree that if you set your exam questions, you don't mark it on paper, right? so I think that there's a certain, and obviously reputation is extremely important. So there's and For Humanity has a third-party independent audit of AI systems framework, which sort of is in line with what yesterday's panel, if you saw the US government Office of Accountability as well, they've got a similar framework, but I think For Humanity is much deeper and much more detailed. So the role of a third-party auditor or audits coming in and assessing your governance framework, in your case, Wen, right? And then providing the extra assurance to your customers, the society, that what you have been doing, right, is right. It meets all of the criteria that humans would like to see met, okay, in terms of how AI systems can be run or should be run. So to that, so I just want to get your thoughts on, do you think, maybe I'll start with you, Wen, seeing that you have actually built up an AI governance framework. Do you think that will add value to Prudential PLC, the Pulse brand, in the countries that you operate, and also in future countries that you're going into, which potentially, going back to the geographies and the cultural differences, help you progress this and roll this out further?
Yeah, I think independent opinion about our internal process, as you said, is always helpful, right? You cannot work your homework. I think that's always helpful. and welcomed. I think the audit, again, this is the independent audit of AI is something new. What do we audit? Do we audit there's different ways, right? Do you audit the algorithm? You audit the outcome or the process, or governance process, right? I think the result, again, I think either Anjinta mentioned about this control group versus no. But AI is too new, not too new. AI is not new. I got it. 1930s, right? It's the result. You need a lot of data, a lot of trend to look at things. For example, medical efficiency or longevity. Now, I think to be clear, I think it'll be helpful for the firm being audited. What are you auditing? Are you auditing? Define the scope. Are you auditing the algorithm, the data, the model, or the output, or the process? I think for the process, it's probably easy to follow, right? To audit, because you can measure, you can documents, and you can see the meeting notes, things like that. You can actually measure that. It's relatively easy. Auditing the model, I think it's up to opinion. Designer, which model is better? Propensity model versus random forest. I don't know. I think that's difficult. But I think as long as we have clear scope, what do we audit? What expected outcome? I think we definitely welcome that.
Excellent. Ajinta, you talked about black boxes. I mean, it's some regulation. GDPR, in fact, I think bans black boxes, the use of black boxes to process personal data. There's many organizations calling for clear boxes, so basically making black boxes clear. And there are vendors out there that's providing those tool sets to enable explainability of some of these models to the layperson. So do you think that either independent audit of AI systems framework can actually help making black boxes more explainable to, in fact, the whole process of using black boxes, or if black boxes are being used and being replaced by clear boxes, would it uncover these areas where organizations can improve, right? Or in quotes, do a better job in making AI more trustworthy?
Yeah, I think definitely if we can implement a system, if a black box is required just because of the various technologies in use, then I think that it may be that we do allow them to be put in place. Just because we don't understand them doesn't necessarily mean that they're bad. I think what we have to do is say, well, if they're implemented, how are we going to audit them? How often do we audit them? Because there's one thing about auditing a training system or a test system and then approving that and letting that out in the world. And then when that black box, or that not necessarily black box, even a clear box, if you just let it out in the world after auditing it, in a very controlled setting, when you let it out into the real world, as it were, with real world data, you have to keep continuous, almost in a way, continuous audit, or repeat routine audits. And one of the things I've recognized from doing audits in real life is that, say if there's an audit of a hospital about to happen, for that week before and that one day, everything gets organized and everyone's in their best behavior. But actually, that's not the real world scenario. That's not what happens day in, day out. So when you're auditing these, you have to have kind of random, some way of auditing them repeatedly. So that
okay.
Yeah.
Great. Giselle, just to finish up.
Yeah, I think independent auditing and that third party is an absolute necessary. I don't know that if in England, the law required in 1945 auditors and auditing to be used to protect shareholders of public companies from the improper actions of their promoters and directors. So auditing is a mechanism by which you say, we understand that you love this product and this product and service is going to be provided, but in order to protect shareholders, we're actually going to look at you from an independent perspective. I think that mechanism, regardless of vertical, regardless of industry, it has been used by various countries in very successful ways. The financial sector, for example, pick a country. if it's able to be done in a financial sector that can be very complex, and in other sectors where it has been used as well, in some aspects in the transportation industry as well, why not AI? Why not in information technology? Why not in technology in general? It's absolutely necessary.
Great, thank you. Thanks for summarizing that. So we've got 5 minutes before we have to close. We've got some questions in here, and I know that Ajinta, you've been picking them off as we discussed the other topics. I'm just going through. There's one for Wen here. Following the rollout of Pulse across the various Asian markets, have you started to observe a decline in claims due to the sheer features of the application?
I was busy typing the answer, but I'm the question. Okay, all right. So I'll share that. I'll type it anyway, complete typing. But I think so. It's too early for us to show any statistically significant movement. And also, but I thought also point out is even over the long term, we don't just measure the number of claims. So the whole design principle is we roll out those, symptom checker, health assessment, so people can use this service more often. For example, in the old days, you had to travel days to see a doctor. You may say, well, I'll just put up with it, right? But now with this service, you can actually try it 24/7 from anywhere. So we catch diseases with illness early. So even though it's not just the amount of claim the customer will submit, policy holders will submit, but also the claim amount. Because the logic is if you treat something early, catch early, treat early, claim early, you actually don't have to suffer from subsequent. So any disease, illness, if you treat early, the cost is much lower than if you treat in the later stage. So I think this is, by the way, this is not a measure we use, right, to measure it. This is internal measure, but I just want to, if we do measure, I think if you do try to measure it, it's not just the number of claims, but also the value, because early detection save lives and it reduce the cost for insurer.
Makes sense. Makes sense. Clear. Thank you. I've got one here, but I don't think any of you have claimed that. So question, how can vendors support the medical complaints process? Do they feel that that has been scaled or skilled to cater for AI-driven outcomes? Who wants to take that?
I can just say, do they feel that they've been scaled? No.
Yeah, do they feel that that has been scaled and skilled to cater for AI-driven outcomes? I guess it's about the complaints process, right? If your AI decision is bad or wrong or whatever,
no,
is a complaint.
It has neither been scaled nor skilled, in my opinion.
Okay. So how does, have you had any of your customers raise any complaints about the decisions or diagnosis made by Pulse?
Okay, so let me answer this question a different way. So Pulse is actually not a medical device, right? So we provide a device.
Yeah.
Basically, say and also we offer services like you mentioned, human in the loop.
In the loop, yeah.
For example, if we provide diagnosis, if it's straightforward, it's fine. And if not, we'll offer a service we call telemedicine. So they get a chance to talk to a real doctor, right?
Okay.
And we're very clear that this is not a medical diagnosis, and it's for your advice. It's medical advice. That's the first thing. And second, I think, you mentioned about the compliance. Again, I say the case I gave you earlier. Well, the image recognition, pattern recognition for X-ray replace lab technicians? No, it make them more efficient. So we still have the human in the middle and also we have the human accountable and also the technology accountable, the technology provider accountable for the output. And they have to demonstrate that they comply with privacy and things like that.
Yeah. Sorry, it's not compliance, it's complaints process. If there's a complaint.
Yeah. I think no, we haven't. Sorry, I was trying to find the question where the question is.
It's the second question in the the Q&A.
No, we haven't get the complaint. Oh, sorry, my second point. We also talk about we build the model to be unbiased, but sometimes we intentionally add a level of bias, because if you do a true positive, what was the word? True positive or true negative, right? Because if you make a wrong diagnosis, somebody had cancer, it's more serious. So we introduce a level of bias in there that we'd rather, if there's any doubt, we would actually consider to be, I have to go back, true negative, true positive. I'm always confused about this one. So I think that's is responsible, right? It's a responsible way for a supplier, for insurer. And so far, we haven't got any complaints. But we do have a lot of follow-up service. They want to talk to a real doctor. But by the way, we also make the real doctor more efficient because the data customer enter will also be fed into the doctor, so they don't have to ask the same question again and again.
Okay, great. Have I missed any questions? Jinta, go on.
Oh no, I was going to say I can probably answer part of that as well. So one of the things with the medical complaints process is that, it's a bit of talking about black boxes. It tends to be quite a black box. So I think that explainability and transparency is a key element to improving the efficiency of the complaints process, and also explaining the process beforehand. So when you have a complaints process, it's really important for the person to understand what are all the steps that are going to be taken for this complaint to be handled.
Yeah.
So, or not necessarily all, but some of the steps ahead of time. So then they can prepare themselves, and it gives a lot greater level of trust and also greater level of information to be able to then handle the complaint properly, rather than if you have it in a black box and don't have that explainability, then it makes it much harder to address the complaint first, and also to address the person making that complaint as well.
Great. Okay. Thank you, everybody. I'm afraid we've run out of time, so we have to wrap up. Thank you very much for all your time today and your participation. Super set of discussions, and really appreciate your participation in the conference as well. So thank you very much. I like to also remind the audience that there are 2 sessions coming up after this, and they are the children's services and online toys, or the space systems. They run in parallel, so you need to pick one or the other, unfortunately. Or if you register, then you may be able to watch the replay. So thank you again, and enjoy the rest of your day. Thank you very much. Cheers.
Thank you.
Okay, bye.
Bye.